Wait, but does it?
Steve.
It doesn't record this
I'm gonna
direction.
turn it around. We just wanted to get it started. There's only one participant, which is us. Okay, stop the video for a second. I think something I haven't done.
Yeah.
There is so much junk on this desk. Do you think we need to? No, we can just slide it up. Here we go. Let's. Yeah.
I didn't know if we would be. Oh.
Look at it. That looks great. Awesome, guys. We're on mute.
Thanks for letting us.
Thank you. Sorry.
Sorry, it's a lot of, I'll check my for anything.
All right, okay, so we're gonna go over poem and G poem, essentially all third space endoscopy. So it's called third space. I'll take a step back. You have conventional open surgery, and then somewhere in, I'm not sure the surgical history, but when laparoscopy kind of came around, but probably in the 70s, 80s, and then it took off from there, laparoscopy. So less invasive form of conventional surgery. And then after that took off and really showed that, hey, you can do this just as well as conventional open surgery, which the old school surgeons were very skeptical originally, but instruments got better, everything got better, techniques got better. So then that showed that really, if you're doing a appendectomy, gallbladder surgery, now even, posterior tracheopexies, they can do it thoracoscopically. So that took off. So then people started saying, well, what's the next least invasive way to do things? And that would be to not even have any ports through the skin. So not through the chest, not through the abdomen. So how can you do that? Well, you can use a natural orifice. So mainly your mouth, your nose, your anus, your urethra, things like that. So that opened up the field of natural orifice transluminal endoscopic surgery, or NOTES procedures. So NOTES procedures is the term for any real conventional surgery done through a natural orifice by endoscopic means. The first people that tried to do it were going through the mouth to the stomach. We had stuff to suture, kind of rudimentary. We had clips, but they would just cut through straight a hole through the wall in the stomach, drive your scope, wash things out, drive your scope into the peritoneum, go down to your appendix. Kind of hard to get down there. Got to go through all the intestines and everything. And then you get down there and you essentially suture off or clip off the cecum and cut off the appendix and take it out, right? You can do it, and then you come out through the stomach and you've got a hole in the stomach, and now you've got to close the hole in the stomach. You can do it, but what you're competing against is with established laparoscopic surgery, where your complication rate from an appendectomy, even a non-inflamed even an inflamed appendectomy, is really low. So you're talking 2% complication rates, and they were never able to get that complicated procedure where you're leaking bile and saliva into your peritoneum the whole time you're doing the surgery to be a complication rate that low. So people started abandoning a lot of NOTES procedures. They had done gallbladder, they had done appendix, and then they had done transvaginal surgery also, because then you at least don't have saliva and everything coming downstream to go up and do it that way. but it fell out of favor just because of infection rates and things and weren't where they needed to be, right? So, but then in 2009, Haruhiro Inoue from Japan, who was a surgeon, decided, well, they had been taking off. So step back. In adults, they have cancers in the stomach. In particular, in Japan, they have a lot of cancers on the surface of the stomach. And if you get to them early enough where they haven't invaded, you can inject underneath, just like you would lift the polyp, inject underneath and use a knife and cut under it and cut it out and stay in the stomach wall so you don't have a perforation through the stomach. So that's called endoscopic submucosal dissection. You dissect it out and then you take it off in one piece, and it's better than the piecemeal way that a lot of adult GI would do it with the endoscopic mucosal resection, where they just suction it into a cap and cut it off with like a polyp snare. But then the cancer comes out in pieces, and you don't know for sure you have good margins, so you have it all. So they were doing a lot of this endoscopic submucosal dissection, and they were doing it then also in the esophagus for esophageal cancer, superficial esophageal cancer. And when they would do that, they would be injecting under the lesion and driving right over the muscle of the esophagus, sometimes down right to the lower esophageal sphincter, and then taking this out and leaving just an open muscle space that would heal over. Well, achalasia is a problem with the lower esophageal sphincter. So you lose peristalsis of your esophagus. That lower esophageal sphincter doesn't relax. So normally you swallow and your upper sphincter relaxes, the food bolus goes down, your esophagus contracts and moves it with peristalsis down. And when it gets down to the bottom, your lower sphincter relaxes, pushes it through to your stomach. The problem with achalasia, you lose, for the most part, you lose the coordinated contractions in your esophagus, and that lower sphincter stays closed. So with the lower sphincter staying closed, you can drink, eat, and it just sits there, and it might trickle through a closed sphincter, but stuff will build up. Your esophagus distends, you lay back at night, and food that you ate from hours before rolls up to your mouth, and you wake up coughing and things like that. So the traditional surgical approach is to either go through the chest or through the belly, laparoscopically most of the time now, and go to the outside of that lower sphincter. You've got to dissect to it, cut the muscle from the outside, but not cut through the mucosa, because you want to keep the barrier from dirty stuff on the inside from leaking out into your chest, abdomen. So they would cut from the outside. If they did make a nick, they would have to suture just the mucosa, which is a little tricky because your sutures can tie through and rip through and things like that. But that was effective. But Dr. Inoue was looking right at the muscle. When he had patients with achalasia, he said, I could just do the same approach, tunnel over the muscle, and then cut the muscle, and then come out through the tunnel. And the big difference, the reason why this became the first successful nose procedure, is this tunnel that you make. Because if you imagine the hole in the stomach when you were doing nose, they were just poking a hole in the stomach so everything could leak out and driving your scope through it. Now, to get to the surgical site in the esophagus, what they do is they come up above it, make a big saline bleb, cut into that bleb, you're in the submucosal space with your scope, and you just dissect with a knife down in that submucosal space. So on one side you have mucosa, on the other side you have muscle, and then you go down all the way onto the top part of the stomach, the cardia, a couple centimeters down, 2 to 3 usually. And then you see the whole muscle, and then you can cut the muscle, and then you stop cutting the muscle a couple centimeters down from the opening of the tunnel. So when you come out and you close that tunnel, even if there were a small minor leak in there, it wouldn't be leaking out right into your chest, because it would have to leak out, go into a submucosal space, track down through that, and that area wants to heal immediately. The best, if you imagine, like, here's my skin. Imagine my lower sphincters at my wrist. And instead of cutting a hole right through here, cutting the muscle, and then trying to close it here and hope it doesn't get infected and leak, instead, you take like a TB needle, go here, make a giant bleb of saline, cut in right there, and take like a a scope, a thin scope, slide down, keep dissecting down to that area. Then you cut the muscle down there, and then you pull out of that tract and just close a little opening several centimeters away. Now, if there were to be some infection in the area where bacteria get to, which is like at the opening, they might get into there a little bit, but in order to cause a problem, they'd have to leak down that whole tunnel, and that you can imagine that submucosal space just seals right up on itself right away. Just like, you do a TB, you're disrupting that submucosal space when you put a TB syringe in and inject it, and it just expands up that whole submucosal space, but it's all tissue that it just reforms right away. So that's how this became successful. All right. So achalasia poem, which stands for per oral, so by mouth, endoscopic with a camera. Myotomy, it just means cutting the muscle. Otomy is cutting my muscle. Right. So the poem was the first one for achalasia, but then that extended the same techniques for in the colon, but less so, but more so in the stomach. You can tunnel there and get to the pylorus. And so the term for that procedure is called G-poem, so gastric per oral endoscopic myotomy. Some people call it POP, per oral pyloromyotomy, but I think G-poem and poem makes more sense. Everyone knows what you're talking about. So that's the terminology most people use. So G-poem is also now widely becoming accepted, and the complication rates, there have been numerous studies that show that in particular poem and Heller, that the complication rates are no worse or better. Hospital length of stay is shorter. The myotomy is as complete. You can actually make a longer myotomy for certain types of achalasia. So for some achalasia, you have a very spastic lower esophagus. So you can start your tunnel higher and do a longer myotomy so that spasms in the lower esophagus, you also treat those instead of just that sphincter. They can't do that as easily from the belly because you can't get up as high safely. Poem has its own CPT code as of 2022, and G-poem not yet, but people are just using the poem code. And most insurers are now covering it because it has a CPT code, and it's cheaper for them. I mean, the same Heller myotomy costs more. Some of the surgeons that are old school will say, well, when we do a Heller, we often do a fundoplication, and that's better because when you do the fundoplication, then you prevent reflux long term, which is a complication of a myotomy because you're cutting the muscle that at the sphincter, you're going to make it easier to swallow, but there's no way to keep it just as hard to reflux. So reflux is an issue, but we at least think, the studies haven't totally proven it out yet, that if you're not going with surgical instruments from the outside and taking down all the ligaments and things at the diaphragm hiatus that hold your sphincter and the angle of His, which is the angle that stuff comes into the stomach, if you're keeping all those structures from the outside the same with poem, you may have less need for that fundoplication. So far, we've only done 2 follow-up endoscopies to check for reflux on our 14 poems that we've done so far. And so far, neither of them have any esophagitis off of acid suppression. So that's good. It's supposedly like 30-40% of people that have some reflux esophagitis that need ongoing acid suppression. So we tell people that from the beginning, but they haven't needed fundoplications. They could always get it later. So even our surgeons who do Hellers don't do a fundoplication at the same time because they're kids and they're like, let's just do the myotomy, and if you need it later, we'll do a fundo.
Is that with testing using the endoflip or just from visually looking?
That was visually looking for esophagitis, which is a better way of looking. The endoflip, that's important too, because endoflip, you put the balloon down. It's not a dilating balloon, it's a low pressure balloon, but you can put it against that lower sphincter and inflate it. And it shows you the diameter along the whole length of the balloon. And then it can tell at what pressure, what diameter it is. And from those 2 numbers, it can calculate a distensibility. In other words, how easy it is to distend or stretch the lower esophageal sphincter. So if you have achalasia, you can imagine it's closed, tight, doesn't want to relax, and you get very low distensibility. Usually the number is less than 2.8 in distensibility for achalasia that's untreated. When you do a myotomy, you want to get that number usually above 4. Above 5 is where Sam and I aim for usually. And then And then that means that it's easier to open up. And you also can easily get the scope through it. And then on contrast studies, stuff will drain through faster. So that is something that we employ. Not everyone does that, but we do an endoflip at the beginning of the case and at the end of the case. At the beginning of the beginning before myotomy and after myotomy, but before we close the tunnel. That way, if the numbers aren't where we want them, they can go back in the tunnel, do some more myotomy, extend it a little longer, a little wider at the lower sphincter. All right. So,
Can I ask you a question? What is a CPT code?
oh, CPT code
Yeah.
is the billing codes that we use for certain procedures. There's one for EGD with biopsy, EGD with foreign body removal, EGD with whatever.
So now there's one.
Now there's one
nationally
for
or just-
POEM. Nationally, it's
Okay.
by whoever makes CPT codes.
And what's the difference between G poem and poem?
So G poem is you're doing the same technique, but on the stomach, starting at the antrum, you tunnel there to the duodenum, pass under the mucosa to the duodenum, and then you cut the muscle of the pylorus, which is the exit to the stomach, as opposed to the lower esophageal sphincter. So it's the same type of procedure, but two different locations.
And you're doing the lower esophageal.
I am, but I'm scheduling my first G poem coming up, and then there are a couple other ones that probably need it. So, and there are 4 centers in the US that do poem and pediatrics, 2 surgeons, one at Stanford, one at DC Children's. Myself was the first doing pediatric GI, and Muhammad Khan now, who did adult training at Nationwide Children's, does poem and G poem also now. Kids, yeah.
Oh, sorry. Go ahead. I was gonna say the G poem is, pylorus is usually done just on babies. You're not. Don't
So-
typically do that on older patients, right?
So that is the most common reason for a pyloromyotomy is on infants with hypertrophic pyloric stenosis.
Yeah,
They are very small.
right. That's what I'm asking.
yeah. So our equipment doesn't totally fit well with them. You could do it with an XP scope, but you're limited by the channel size with all the instruments. We can't use almost any of what we
Yeah.
have here right now. So we could use that little needle knife that we use in EA for like just making simple cuts, but it's less, doesn't have as much capability. So it's been done. China, a guy in China who Pinghong Zhu, who's reported like over 2,000 poems, did 21 kids throughout China, infant pyloromyotomies, and was successful in like 20 of the 21, something like that. So it can be done. Whether 10 years from now, like poem in infants is gonna be, or G poem in infants is gonna be the standard instead of the quick laparoscopic surgery. I mean, it's 2 to 4 out of every 1,000, out of every, oh, it was 2 to 4 out of 2,000 live births. I mean, it's like the most common surgery in pediatrics. So if it were to move in that direction, like I could just get busy doing G poems on infants and be like, I don't do anything else. Like, you know, that like, and
But
so
your upcoming one is not a
no,
baby.
no. So the ones that we're doing to start off with are adult sized patients. Like I started with poem, only
Yeah.
adult sized patients, but the techniques now you can use them down to kids that are under 5 even. And we're using standard size endoscope. But these are patients with severe gastroparesis.
Gotcha.
In adults, they do it for diabetic gastroparesis and other things like that. But we have a lot of kids with, you know, POTS and gastroparesis and other motility issues where mostly Alex Flores DAM patients that, you know, have chronic vomiting and things like that, that we're on erythromycin and other prokinetics. Might do pyloric Botox. Right now, we do a lot of pyloric Botox to try and help open up that lower sphincter. A more definitive way to do it would be to just go up and cut the sphincter and open the sphincter. Right? You wouldn't have to be doing Botox, but you know, there's some complications. All right, let's go over the stuff. So this is the Irby Tower, which we don't own. Which hopefully we will, but this the top Irby is the same as our standard Irby. Could I turn it on? The main difference is that this one is just a newer version. It is touchscreen. The other one was not touchscreen. The other one has a screen and it has more ports and it's a different connector for the port. The other thing is that these they recognize the device when you put them in. So the settings that are Like it will have normal settings. So eventually, when our old Irbies die, assuming we stay with Irby, we would replace them with this module, which is the Vito 3. And then see how there's like polypectomy setting, and it would just
Yeah.
it would show you the different things for polypectomy, like a polypectomy loop, ABC probe, things like that. And then there's different kind of settings for there, but I'm not going to go through all the settings. So we're just going to go to poem. You don't need to worry about these settings because I'll manage the settings. Right now we have nothing plugged in, so it won't tell us anything. But on the pedal, which is down there, there's a yellow pedal, a blue pedal, there's a black button at the top. That black button is actually useful. You can use it on the other ones as well. And what that black button does is it switches different settings that you have pre-programmed. So there's incision myotomy, tunneling, coag grasper, SB knife, low force coag, and then set up already is the hybrid knife, coag forceps, and the SB knife. Not everybody uses the SB knife. I use it just to cut the muscle as with scissors. And then there's settings here for it's under like tunneling. It would be precise sect and soft coag, but no need to worry about those things right now. One of the differences is when you would touch the device, and then it will tell you where to plug it in. So, and then once that's plugged in, if I were to then touch coag forceps, it would say plug it into the next one down. But now it's saying to plug it in here because there's nothing in here. And they're already preset with endocut, precise vividly. And the new ones for these, which if we move to them, they just go from a scale of 0 to 10. So there's no more of this voltage, wattage, whatever, which actually I think we went away with when we got rid of the old Irbies. Somebody might remember. Okay. This is what we don't have. This is the main thing we don't have that makes it harder to do poem without it. This is a Irby jet. And so what that does is we're actually going to set it up. How much time do we have? Okay. All right.
Why don't we own this? The Irby.
Because following COVID, there was capital budget issues.
So you borrow it?
It's $70,000. Not much, but yeah. No, it's not that much.
So you borrow it, Peter?
So they bring it in for me every time, and they're doing it so much they just left it here.
We're not supposed to use it for anything else.
No, you're not. It's only for poem right now. And it has to, if it leaves the hospital, like if they take it over to the Brigham to demo something and then they bring it back, then it has to be rechecked by biomed.
So you want to get at least a couple days in advance so biomed can come up and inspect
If
it
it's
with their
left.
sticker on it.
Right, yeah.
Okay.
Yeah, they have a document taped on it, but Irby owns it. Okay, so this is the Irby jet module. The reason this is important is in order to do your dissection in the submucosal space, you want to expand up that space as much as possible. So just like you would like with a TB syringe is the best example. You stick it under in the submucosal space, you inject and it lifts up. That lifts your mucosa away from where you are tunneling. And that's the most important thing you want to do because you want to protect the mucosa, because the mucosa is the barrier between your dirty esophagus and saliva and stomach and the clean tunnel that you're in. So if you accidentally make a hole in there, you can fix that hole, but you want to limit that as much as possible. So what this does is through the knife that you use, the very end of the knife, it's called a T-type knife, and that's because out of the catheter, it's straight, and then there's a little disc at the end. So in cross-section view, it looks like a T. So it's a T-type. There's also an I-type, which is just a straight one. And then there's like 9 other knives by different companies. Irby is the only one that has a hybrid jet. And what that has is through the tip of the knife, there's a like almost microscopic hole. And this machine shoots out a jet of whatever liquid you want at very, very high pressures. And so the water jet itself can dissect in and inject like a needle would. If you don't have this, you can still do a poem, but you then have to use a regular injection knife, and you have your knife coming through your scope to do your tunnel, and then you want more of a cushion of saline to like spread open that space so you can cut in the submucosal space. You have to take out your knife, put in your needle, inject saline to blow it up, take out the needle, put in the knife, cut a little bit more, and you probably get about what, 2 minutes of cutting time, 2 minutes, and then you got to take it out, put it in, inject, take it out, put it in, cut for another 2 minutes, take it out, put it in. So it's a lot of exchanging otherwise with the knife. You can do it though, but this one, you just essentially, you're cutting. You want more space, you step on the injection pedal and injects through the front of the knife, blows the space open, cut, a little more, you can inject. And all of that fluid just gets absorbed right away, just like a TB submucosal injection disappears. Okay, this one important thing. This thing, when it's plugged in, the Irby doesn't want you to reuse this thing because technically, like, no blood ever comes back to it. So they make it pretty single use. So much so that if you plug it in and the thing gets unplugged and you plug it back in, it says replace the used cartridge. So we don't want to have to do that
Because these are really expensive.
because they're probably expensive. Yeah.
So we always put it across. So if Peter's here, we always put it across the machine here, set it all up before the patient comes in the room, and then we push it back.
And that way also I can see the settings there. And there's four pedals here. So you have, usually I'm using the blue pedal, which is the precise sec. And then I go from cutting to this pedal here is the hybrid knife that inject. This one here is your standard water flush one that I only would use pretty much if there's bleeding, there's excessive bleeding. I cut through a vessel and it's bleeding. Then rather than just see all red, you can just flush with water if you need to clear your view. You can see where it's bleeding from. And then we have devices to kind of grab that, stop bleeding. Goal is see the vessels before you cut them so that you coagulate them and they don't bleed. Okay. And this is the pedal that I mentioned that you can see it changes coag grasper, SD knife, precision myotomy, tunnel. Okay. Patients usually on their back, just like we do a lot of the therapeutic stuff. Monitor I usually put right there. We don't use fluoro with it. This is a scratch pad just to clean off the tip of your knife. Yeah, the tip of that knife. That knife works like any other, like the endocut knife. You know, like
Like that.
Yep.
And that's the one that injects the fluid.
That's the one that injects through. Let's put the
It's in.
let's set this up.
So what you want to do is you want to get some methylene blue from the nurse in the OR. And you're gonna need this special needle tip here, and you're gonna drop 1 cc of the methylene blue
In a filter straw.
in a filter straw. Thank you. Yeah. So you don't get any glass particles in it.
Okay.
Well, you can imagine that this whole thing is filled, okay? Then I have a cup here, I just stand it up in because that makes a big mess. All right, and then
That goes into-
take our container of saline. Sorry. So what we want to do is inject 0.5 ml into this bag, so it's alcohol, and I would inject.
I put in the order for the methylene blue. I don't put in a dose. We just dilute it ourselves. There isn't necessarily a standard. You'll see what 0.5 ml looks like. So
That's normal saline.
this is
Normal saline.
normal saline. Inject, well, it's obviously sterile. So you want it about the color of Windex. Right.
It's like, yep.
Yeah, so 0.5 is what we've been using. The reason you use this is that the submucosal space fills up with this stuff, with this liquid, and so it stains blue. Whereas the muscle stays a white color, a whitish pinkish color. And so that helps you see where the muscle is and see the submucosal fibers, and you cut through the submucosal fibers and then get, coagulate any vessels along the way. And you want to stay close to the muscle because on this top surface, you have mucosa. You don't want to poke a hole through there because then you'll be in the esophagus again. So other things, yeah, so let's finish it.
So you take a secondary medication set. And you put it in. And then we're gonna prime this through. And hang it over.
Yep, yeah, put this. I just put this thing through there to hang it onto here.
So a lot of times we just hang it from here. Once we get it all primed, you can hang it from a pole as well, depending if you have one, the time.
You do want to make sure the liquid primes all the way through the whole thing till it's dripping. So
So
if you
I'm
need
actually
to,
hang it up,
go like this to get it dripping.
get it
all the way
primed through. Okay. There we go. Done.
They don't want you to touch the tips of those cartridges.
Okay, so you don't touch these ends. And this, it's gonna go in like this so
It
that
goes
your
back here.
little port is off to the right. You just plug it in like that and push in. And then it's gonna do this configuring in the machine, so you gotta give it, so we're gonna hit okay.
Okay, for poem, and then it says, yeah, 435 PSI, so it's like really high pressure.
So it's connecting to the cartridge, it just asks you to wait. Okay,
Connecting completed. So the next thing is prime, so now we just need this thing hooked up. We did have once not have the liquid all the way through, and it wasn't priming, it wasn't pulling the liquid through. And if you want, you can, in the prime part also, oh, we gotta make sure the liquid, right?
we can actually hang it from the pole if it makes it easier.
That-
Connected to the knife.
No,
No,
the knife will plug in through here. This cartridge like fills up with some liquid. We often do connect it to the knife first, so that way it primes through the knife. But the priming sequence, the knife you can plug in afterwards, it'll still work.
Okay.
So.
So we're
all right,
ready to
gonna
prime?
Press button start. You can see it going in. Before it was like going like.
Yeah,
this
I
way.
was with you on that.
And it's going, and there you go, see?
So it'll start to drip out.
It will start to drip out.
Okay.
Yeah.
Okay, and then you
It's
just,
priming through and then in order to,
it stops itself.
yeah, it will stop itself, but then to make sure it works, I can just,
press on the gray pedal to.
and that's
advance
just
the
pushing
fluid.
through. That beep is 1 ml.
Oh, interesting. But isn't that how you prime the knife with your foot pedal?
Yes.
Yeah.
So, but the knife just plugs in here,
So you
and the
see-
knife actually, once you plug it in, you can't get it out either.
Right.
So when we had that problem before and the knife was plugged in, I had to crack this thing open in order to get the knife out to reuse the knife on another one of these. So we didn't have to throw both away.
So right here, this little piece here is circular and that just pops right in there. Okay, and then what you do is you take the knife out of the plastic circular portion there, and then you can prime it with a gray pedal. So it goes all the way to the end of the knife. So this part goes right up into here where the light is. And then this is the device that the nurses will, you guys will manage. So this goes forward and backward. And so when you go forward, it pushes, this is the knife. And then there's a circle on top, which is where the water or the saline comes out, strong force. Okay, but one thing to note, you're gonna notice when you're doing this, if you push the knife out a little bit, it will just eventually slowly go in that direction. So you'll find that as you're going through the procedure, all of a sudden the knife seems a little bit longer. Or like if you pull it back, it will go in that direction as well. It seems to go, it will go in the direction that you push it.
Just because, yeah, you can imagine there's some pressure in the sheath and slowly it moves the direct, like you push it hard enough to get, it's just like when you're spinning a clip. Like you'll spin it and it'll get to where you want and then you stop spinning, but it'll slowly keep going because
Yeah.
there's some memory in the sheath. So if you're pushing it out, it goes out and you think, oh, it's perfect. And then you start doing stuff and it gets longer. So what I usually prefer is go out all the way and pull back to where you want, because that way unexpectedly, it'll get shorter, which is safer than it unexpectedly getting longer for me.
And sometimes this tip gets a little junky on top, so he'll pull it out and then you'll rub it up against this like charcoal pad. It sort of helps to clean it and then you'll put it back in. Okay,
That, the slide thing on there, it pushes the knife in and out.
And your command is, knife out, knife in, or?
Pretty much, yeah, a little
you-
more knife, less knife. There's
Okay.
always some knife. This is not one that pulls into the sheath. There's always a knife at the
Oh,
tip.
okay, gotcha, okay.
So,
So upon setup, do you want us to, so you don't want us to open the knife until you start?
nope, you can open the knife too. I just
And
don't
I
want to
think-
open a knife because it's
Okay,
expensive.
okay, so you can actually prime it and have it ready for you.
Yeah,
Okay.
yeah, because I'm always gonna use a knife. I may not always use a coag grasp, but I'm always gonna use the SB knife.
You know that little insert?
Yes,
Yeah, that is perfect for me.
yes. So the thing is, that has 4 ports. You can plug in all
Yeah.
4 and leave them all 4 plugged in all the time. Then all I have to do is I click to the next one, it'll connect to the next one down. And if it's already connected, you just grab it out of here, it's done. No change. Right now, we only have like 2 cords.
currently
We
only
sometimes
two, but we're hoping
we'll have to
get
change
more.
if we have 3, but if we get the thing, you just get the 4 cords and you have.
Plug them all in.
Then right now, Deb's using this kind
So
of
what
way
we
to,
would do is.
you can open if you want, you could open that,
Okay.
so that's
Keeper.
So
cheaper.
as you can see, we're gonna have a lot of pieces of equipment, so it's, you gotta keep them all on top here, so we're hoping to get a package that we can tape along the side that will have pockets, so that as you use it, you can put it inside. But now what I do is I just take the bottom end of a Kelly clamp and I put it around the equipment piece, and then I do that, and so that I have each one along.
Yeah.
Smart.
See,
Smart.
there.
That's
Yeah.
cool. Oh, I like that idea.
So in this
So
way,
you're
it
not
doesn't
clamping.
fall,
You're
and
You're not actually clamping, crushing anything.
yeah, yeah, you're just holding it in place. So of the other piece, the pieces of equipment, this is the SB knife, okay? This
It
is
looks
the
just
knife
like a kind of a pair of scissors, but it's hot, so I can,
looks like
I
that.
can close on the muscle, coagulate, and then cut it.
Amazing.
There's one other thing Deb, one thing we forgot to mention is we've primed all this, but the very first incision that we make, we have to make that saline bleb. It's
So
hard
I
to
would-
get through the mucosa with, even with the high pressure water dissection, so we use that interject, and so, yeah.
So what we do, so once this is all primed, you want to get 10 cc's out of here into this syringe, and then you're gonna prime the needle, okay? The Carlock needle, and this is the piece he's gonna use first. So he'll inject that
And you
initially
gotta
through
remember
the
to get it out
side.
of here, not
Out of
out
here,
of the
not a
original box,
straight
not straight
methylene
methylene
blue,
blue, or it'll
okay.
be like, we had it and it was super dark, and we're like, wait a minute, there's something wrong with
There's
this.
something wrong here. So then he'll inject into the side to spread the tissue, and then he'll go in, cut, and then he'll make a hole big enough for the scope to go through to tunnel down. So once you tunnel all the way down, you're gonna do the tunneling with this, the hybrid knife. And then when you get to the bottom, to the muscle, you're gonna use the SB knife, and it looks like, an SB knife actually looks like this. And it's plastic on the end, and as you cut through, it gets very junky and the tissue really sticks to this particular knife. I always advise to bring 2 of these. But a lot of times you're pulling this knife out and cleaning it off and putting it back in. It gets very junky, hard to. It's not super.
Do
And
you
then
just
I'm
keep like
gonna
a
do
bottle
one
of like
more.
so
Yep.
saline or something to dip it in?
No, we
Like how
just
you
wipe
clean
it off.
You wipe it off.
Yep. And then this is our third thing, which is the co-op grasper, and it looks like this. And basically, as we're tunneling down, as you get further down the tunnel, near the myotomy area where we're gonna cut, the vessels get bigger, and so rather than using this knife, which can handle small vessels, this can handle the big ones. You can just go right around them and cauterize, cut at the same time. It just takes it out, which is great. So these are your main
This
pieces.
is also this we have, it looks like essentially like a jumbo biopsy forceps kind of thing, but it cauterizes in between. So if there was a bleeder or something that an aged person's dealing with or whatever, and they can see where it's bleeding from but can't get it to stop, you could get this, and it's easy to use.
And and one thing in particular is.
Yeah,
we-
I'll go over the complications now real quick.
Okay.
So as you're doing the procedure, one complication is you can make a big hole into the mucosa, which you can usually clip afterwards and still prevent a leak. Another complication would be you're cutting through, dissecting, you cut a big vessel and it bleeds a lot, you lose your visualization. You can usually use a coag grasper for that to stop it. If you can't see, you can inject epinephrine to help decrease the bleeding enough so that you can still see and then coagulate it. You're just going to use your knives and your coag grasper to stop bleeding. That's what you have. Then the third is that when you do your myotomy, you're through to the chest wall space, the mediastinum, or the abdomen, depending where you are. And when you do that, you can blow in CO2. You have to be on CO2. You can't be on air. So second set of eyes watching is always good. Be like, hey, you still have air on, right? Because that's a big problem otherwise. Because if I blow CO2 in the belly and the belly gets really blown up, and anesthesia is like I tell them, hey, tell me when your airway pressures are getting high. I'll just pause. I can take the scope out and we can chat for 5 minutes and let the CO2 get absorbed, belly get soft again. But if it's air, that won't happen because it doesn't get, the nitrogen doesn't get absorbed through your peritoneum. So, but if you were to do your myotomy and sit on the air too long, which is often a novice problem, like the surgeons who first weren't endoscopists beginning and started doing this, like 4 of their first 8 patients came out with chest tubes because too much air in there and then affected ventilation. What you can do if you get too much air in the pneumothorax, so it gets out into the airway space, collapses the lung, you can use a pneumothorax needle decompression kit, which we've never had to use, but essentially you're just going to go like mid-clavicular line and I'll do it. You come up a little bit and just pop the needle in. These are the ones that once it pops through, it gets dull. And then you put a 3-way stopcock on, you aspirate out and see if the ventilation's fine, and you close it, finish your case. So, and then at the end, you should seal everything off. It's only leaking air out because you're leaking out through the tunnel. But when you close the tunnel, there's no more space for air to get out there, so the pneumothorax shouldn't recur. It's not a pneumothorax from popped lung, it's from stuff you blew in there.
Okay. And is this living in the poem bin?
Lives in the
Yes.
foam bin.
Okay.
So everything should be in the palm bin. We have a new palm that's a little bit larger, so we should fit everything.
You could also do it to decompress the abdomen if you really needed to, but you really shouldn't have to if you're using CO2. You can just wait until it gets absorbed. So intermittently feeling the belly is good because if it's tense, then sometimes it's just air in the stomach that you can decompress by coming out of the tunnel and suctioning it. But if it's outside in the abdomen, then you have to wait. Okay.
Can you talk about the plastic tip
Yes.
and
Oh, yeah,
the
two
hole
other
on
things.
the end of the tip as well as the tape on the scope?
Sure. Yeah. So on the scope, in order to keep a view in front of you, if you imagine your scope is just up against the submucosa, you're not going to have good visualization. So we use a clear plastic cap, distal cap attachment on the end of the scope. Right now we use a simple Olympus one. We also have them in the foreign body bin to suction out food and such. They have a little side hole on them so that liquid can drain out of them. I usually put that at 2 o'clock on my screen. I usually adjust it on because I like it to be not totally straight, but a little bit angled so that the instruments come out closer to through the middle of the cap. And then I use pink tape to tape that on. We tape it on nice and tight because you don't want it to pop up in the tunnel. And then the scope. So when I go in, you drive to the lower sphincter, you figure out where that is, and then I mark that spot on my scope, put a piece of pink tape on it so that I know when I'm in the esophagus how deep down the lower sphincter is. So that way I know when I'm in the tunnel going down when I should reach the lower sphincter. I should also be able to tell from the inside, but sometimes in the esophagus, especially with big dilated esophagus, you could spiral around and not be at the LES yet, even though the distance is far enough, and then that would tip you off to that. The other thing I do is I mark a line on the pink tape that I write to keep it in one orientation. I usually do it right straight up, and that way if my scope is twisting around, then I'll also see that also.
And just to know, when he has the plastic tip on the end of the scope, it sometimes gets occluded with stuff, so he pulls the scope out and you just clean it off.
And clean off the lens to make the lens.
With the cap, don't you line up the dot, that hole you're talking about with the channel on the scope?
I have not necessarily,
Okay.
but yeah, and I mean it's probably there's some people just like to say, well, it's better to put it dependent, like so that stuff would drip out of it. But really, it's probably, I mean, if you're doing poems in different, you could do it at 2 o'clock or you could do it at 5 o'clock and it would be different. So, you don't
Since time is up, can we quickly talk about how do you make your way out and what do we need to do
yeah,
on that?
that's right. So after you do your myotomy, you come out through the open tunnel. We set up the endo flip and do the endo flip. Right now, Sam's coming down for all of those. He may not need to in the long run. We'll figure that out over time. But we do the endo flip, measure the measurements. If they're where we want, then we're done with the myotomy. Then we just have a 1 centimeter, maybe 12 millimeter, 15 millimeter opening in the mucosa of the esophagus, and that we have to clip. So we clip that with regular clips. You can use the overstitch, which is a Apollo endoscopic suturing device. It's a really big, it's better with a 2-channel scope, which we don't have. So we don't use that, maybe in the future, but not right now. But clips work very well. You go down that opening, it's a oval opening. We clip it typically like zipper it up from the bottom up. So we do want to make sure we're rotating well. I usually twist at the port and you guys twist clockwise or counterclockwise, whichever direction is best to get it where we want. And then I often will close and say, don't like it, open, adjust it, close, and then deploy, obviously, when you deploy. The one problem we had was like a very first poem where we close, you imagine it's like this oval, close, close, close. And as we're getting to the top, instead of closing like this, it started to roll inward. Like, so you're closing mucosa on mucosa. And then it kept rolling inward. And even if you went up higher, it was like a little tract in the mucosa that led down to the area. And I didn't like it at the time either, but we said, it should be fine. And then the next day when we did the contrast study, he had a little bit of a leak there and we took all the clips off, reclosed it, and he did fine. And he's the kid that we just did last week or earlier this week, yesterday, for a follow-up scope. And when I last saw him on Zoom, he told me, he's like, oh wait, Doc, like before we leave, what was the name of the condition I used to have in my esophagus? And I'm like, achalasia. But thank you. That's perfect. That's exactly what I want to hear. So.
Is Zankers common in kids?
Zankers is not common in kids, but Zankers is a diverticulum you can also treat with third space endoscopy, poems-like technique. You make a hole, you dissect out the Zankers, you cut the wall in between them, and then you close it, yes. Other things you can do with third space endoscopy is anything you need to do in third space. So like GIST tumors are not high malignant potential. They're malignancies, but they're not high like metastatic disease potential. You can take those out endoscopically if they're small enough and just to debulk the tumor burden in the stomach. Right now, Chris Weldon sees a lot of those. I'm lobbying him. When you have GIST you need to take out, let me know. I'll just take them out endoscopically. Okay.
Thank
There's
you.
one thing I do want to mention about the endo flip is, so Sam will handle all of this and Peter is first in this as well. But I just want to let you know that when this is on, we've done our study, you want to make sure you stop it and close it before you actually turn the machine off or the study will be lost. Okay, so that's just to know. And then let's say Sam isn't able, who's in the
What is the muscle that you're actually putting? I know you don't put down on the pylorus, it's the one between the esophagus.
Yeah, the lower esophageal sphincter.
Okay,
For poem, that's the muscle you
and the
cut.
G poem is the pylorus.
G poem is the pylorus. And you clip, you don't clip the muscle, you just clip the opening in the mucosa. And then if there were any small accidental mucosotomies, meaning otomy, meaning hole. You may accidentally made a little hole in the mucosa. You have to clip that also so that it doesn't leak through that into the tunnel and out also.
And that would mean getting a second tower and an XP scope so we could go down, right? You wanna mention
No, the
that?
accidental mucosotomy is what you can just do with your regular clip, but when we did use a second tower, we have, so there is a technique where if I dissect all the way down, I think I'm in the stomach far enough, but I'm not sure. Sometimes in order to tell, most commonly, you just take the injection, you inject methylene blue superficially near the mucosa. It should be blue in the stomach. When you come out of your tunnel, you go down to the stomach and you look and see, is it blue there? Hard to see through the mucosa sometimes, but if you can see that, then you're comfortable. If you can't, you can leave a scope at the end of your tunnel with the light on and then get a second tower with an XP, go down alongside your other scope into the stomach, retroflex and see where's the light. That way you know where the end of your tunnel is to make sure it's far enough past the lower esophageal sphincter.
Thank you, guys. We definitely have to wrap
Okay.
up at this point. This was an amazing, amazing thing. Thank you so much.